Hi guys, I'm back again with a new video, and here this video also belongs to the subjects otorhinolaryngology. We have been covering the part auto, that is ear, from the ENT, and what I have discovered that I have left behind few topics, like as you can see over here. One topic is Meniere's disease, then otosclerosis, otalgia, and tinnitus. So these are the topics which are remaining, and now we will start complete this topic, and then I'll introduce you to something very bigger and big announcement we can say. So first let's cover these topics.
बघितलं ना ब केलं ना मग ब हे बघ उदित अरे ते वाट बघते तू काय आहे.
So let's begin with basically complications of suppurative otitis media. So here we have to understand that there is a general decline in the complications, and there causes a poor socioeconomic condition, lack of education and awareness about healthcare. These basically are responsible as the main predisposing factors. Now let's see what are the factors which influence the development of complication. So as we discussed, age is one of the factor, then poor socioeconomic group is a factor, virulence of organism, immunocompromised host, preformed pathways, like infection can easily travel beyond the middle ear cleft and is performed pathway exists. Then dehiscence of bony facial canal, previous ear surgery, fracture of temporal bone, stapedectomy, then perilimb fistula and congenital enlarged aqueduct of vestibule, cholesteatoma, that is osteitis or granulation tissue in chronic otitis media, destroy the bone and helps the infection to penetrate deeper. Now we'll discuss about the pathways of spread of infection. Direct bone erosion, process of hyperemic decalcification in acute cases, and in chronic cases it may be osteitis, erosion by cholesteatoma and granulation tissue. Next is a venous thrombophlebitis. Veins of Harvesian canals of bone are connected with dural veins, which in turn connect the dural venous sinuses and superficial veins and brain. And the infection from the mastoid bone can cause thrombophlebitis of the venous sinuses and even cortical vein thrombosis, leading to encephalitis. This mode of spread is common in acute infections. Next is preformed pathways, as we discussed over here. Congenital dehiscence in bonifacial canal, then that of the middle ear over the jugular bulb. Patent sutures like petrosquamous suture, previous skull fracture like fracture site heal only by fibrous scar which permits infection. Surgical defects, oval and round window, infection from labyrinth. Now let's classify the complications. We have classified the complications into infratemporal complications, that is within the confines of temporal bone. So in that we have basically mastoiditis, petrositis, facial paralysis and labyrinthitis. Then basically what we have is intracranial complication. And if we have extradural abscess, subdural abscess, meningitis, brain abscess, lateral sinus thrombophlebitis and otitic hydrocephalus. Now let's see sequelae of otitis media. What can be the sequelae? So as you can see over here, in the sequelae, first what we have is basically the perforation of tympanic membrane. Second one what we have is a ossicular erosion. Then what we have is a atelectasis and adhesive otitis media. Yesterday we saw in the video those only same. Then we have what is the tympanosclerosis, and last one what we have is basically cholesteatoma formation. Then what we have is a conductive hearing loss due to ossicular erosion and fixation, and next what we have is a sensory neural hearing loss. Speech impairment and learning disabilities. Now, next part is basically, the last two are secondary to the loss of hearing in developmental phase of an infant or a child. Infratemporal complications of otitis media. In the first, what we have is a acute mastocytitis. So, what is basically acute mastocytitis? It's an inflammation of mucosal lining of antrum and mastoid air cell system, and invariable accompaniment of otitis media. The term mastocytitis is used for infection spread from mucosal lining of mastoid air cells to involve the bony walls of mastoid air cell system. Next, what etiology responsible for it? Basically, high virulence organism, lower resistance in patient to measles and exanthematous fevers, poor nutrition or associated systemic disease such as diabetes. Acute mastoiditis is often seen in mastoids with well-developed air cell system. Children are affected more, and beta hemolytic streptococcus the most common causative organism, though other organisms responsible for acute otitis media may also be seen. Very often, anaerobic organisms are also associated with mastoiditis and need antibacterial therapy against them. So this is a very good diagram showing the complications of otitis media, as you can see in this diagram. Next, what pathology in production of pus under tension and hyperemic decalcification and osteoclastic resorption of bony walls. Extension of inflammatory process and all these are things. Then we have clinical features in which have symptom pain behind the ear, fever and ear discharge. Sign mastoid tenderness. Important sign of tenderness is elicited by pressure over the middle of the mastoid process. Then ear discharge, that is mucopurulent or purulent discharge, often pulsatile, may be seen coming through a central perforation of pars tensa. Next, sagging of posterior superior meatal wall due to bony part between the intrum and deeper superior part of the bony wall. Perforation of tympanic membrane, usually a small perforation is seen in pars tensa with a congestion and intact but dull and opaque. Swelling over the mastoid. Initially, there is a edema, smooth ironed out appearance which can be felt over the mastoid, but later a retroauricular sulcus becomes obliterated and pinna is pushed forwards and downward. Hearing loss, conductive type of hearing loss always present. General finding, patient appears ill and toxic with low grade fever. In children, fever is high with a rise in pulse rate. Investigations. Blood counts. Blood count shows polymorphonuclear leukocytosis. Erythrocyte sedimentation rate is usually raised. CT scan temporal bone shows clouding of air cell due to collection of exudate in them. Bony partitions between air cell become indistinct, but the sinus plate is seen as a distinct outline. In later stages, a cavity may be seen in the mastoid. Ear swab for culture and sensitivity against aerobic and anaerobic organisms, and selection of proper antibiotic. Talking about differential diagnosis, basically suppuration of the mastoid lymph node. Scalp infection may cause mastoid lymph node enlargement and suppuration leading to abscess formation, but in such cases, no history of preceding otitis media and ear discharge or deafness. Absence is usually superficial abscess. Next is furunculosis of meatus, which is differentiated from the acute mastoiditis by this following point. Here, what we have the point to differentiate between furunculitis and acute mastoiditis. First point being basically absence of preceding otitis media. Second point being painful moments of pinna. Then pressure over tragus or below the cartilaginous part of meatus, causing basically the excruciating pain. Third being swelling of meatus, which is confined to basically cartilaginous part of meatus only. Fourth being discharge, which is never mucoid or mucopurulent. Mucoid elemental discharge can come only from the middle ear or the external ear, which is devoid of mucus secreting gland. Fifth is enlargement of pre or post auricular lymph nodes. Conductive hearing loss, mild due to meatal occlusion. and then normal looking tympanic membrane which exclude the possibility of acute mastoiditis. मेरा टाइम ना then X-ray mastoid. So yes guys, these were the point. Then third being the infected sebaceous cyst, that is there is always a history of pre-existing swelling. Then hospitalization of patient, you will come in treatment, antibiotic in absence of culture and sensitivity, start with amoxicillin or ampicillin, meningotomy, cortical mastectomy indicated when subperiosteal abscess, sagging of posterior superior meatal wall, positive reservoir sign, that is meatus immediately fills with pus after it mopped out. No change in condition of patient or it worsens in spite of adequate medical treatment. Mastoiditis linked to complication, facial palsy, then patis paralysis, labyrinthitis, intracranial complications, etc. Complications: subperiosteal abscess, labyrinthitis, and facial paralysis. Petrositis, extradural abscess, subdural abscess, meningitis, then brain abscess, and basically lateral sinus thrombophlebitis, otitic hydrocephalus. Then abscess is in relation with mastoid infection. Post-auricular abscess, this is the commonest abscess, forms over the mastoid. Then pinna is displaced forward, outwards, and downward in infant and children. Abscess forms over Mac-Evans triangle, and basically pus if the cases travel along the vascular channels of the lamina cribrosa. Next being the zygomatic abscess, it occurs due to the infection of the zygomatic air cells situated at the posterior root of the zygomatic uh, zygoma, and swelling appears in front and above the pinna. There is associated edema of the upper eyelid and pus collects either superficial or deep to the temporalis muscle. What we have is known as a beeshold abscess. I'll explain this beeshold abscess in detail. It's an important part. You can see this diagram first about beeshold abscess. That is, here you can see the pus. It's bursting through the medial side of the tip of the mastoid and collecting under the sternomastoid or digastric triangle, as you can see over here. So so what's important to know over here, that is the beeshold abscess occurs following the acute coalescent mastoiditis, when the pus breaks through the thin medial side of the tip of the mastoid and present as a swelling in the upper part of neck. And the abscess may lie first, it may lie deep into sternocleidomastoid muscle, and then basically pushing the muscle outward. Follow the posterior belly of digastric and present as a swelling which is between the tip of mastoid and the angle of jaw. Then basically be present in the upper part of the posterior triangle and reach the parapharyngeal space or track down the carotid vessels. Clinical features being sudden onset, pain, fever, tender swelling in neck, and she giving a history of purulent otorrhea. Next, bezold abscess. It should be differentiated from first a acute upper jugular lymphadenitis, parotid gland lower part, infected bronchial cyst, D being the parapharyngeal abscess. E being the jugular vein thrombosis. So basically, a computed tomography CT scan of mastoid and swelling of neck may establish diagnosis. What does treatment include in this? Treatment basically include cortical mastectomy, for coalescent mastoiditis with careful exploration of the tip of fistulous opening into the soft tissue of neck, then drainage of the neck abscess through a separate incision and putting a drain on the dependent part. Next is administration of intravenous antibiotic guided by culture and sensitivity report of the pus taken at the time of surgery. Meatar abscess, Luke abscess. In this case, the pus breaks through the bony wall between antrum and external osseous meatus, and swelling is in the posterior superior part of bony meatus, and abscess may burst out into meatus. Behind the mastoid citally abscess, abscess is formed between the mastoid more toward the occipital bone. And then parapharyngeal or retropharyngeal abscess. This results from infection from the peritubal cells due to acute coalescent mastoiditis. So yes guys, that was a thing. Then we also have mask latent mastoiditis. Then we have basically facial paralysis, labyrinthitis. Labyrinthitis is an important topic. I'll cover it. So basically what is labyrinthitis? It's three types: circumscribed, diffuse serous, and diffuse suppurative. In circumscribed, basically there is thinning and erosion of bone in capsule. Etiology being chronic suppurative otitis media, neoplasm of middle ear, surgical and accidental trauma. Clinical features being diagnosed by fistula test, and basically it becomes sensitive to pressure changes, maybe membranous labyrinth. Pressure on tragus, that is sudden inward pressure is applied on the tragus and increases air pressure in the ear. Seagull spectrum. Treatment being chronic suppurative. Basically, ampulopetal flow of endolymph within rotation or caloric or fistula test causes nystagma to the same side, and if negative pressure is applied, again it would induce vertigo and nystagmus, but this time the quick component of nystagmus will be directed to the opposite healthy side of the ampulofugal displacement of cupula. Then the treatment in chronic suppurative otitis media or cholesteatoma, mastoid exploration is often required to eliminate the cause, and as the systemic antibiotic therapy should be instilled before the after operation to prevent the spread of infection into the labyrinth. Next we have is a diffuse serous labyrinthitis. Diffuse intralabyrinthine inflammation without pus formation is a reversible condition if treated early. Etiology being most common arises from the pre-existing circumscribed labyrinthitis associated with the chronic middle ear suppuration or cholesteatoma. In acute infection of middle ear cleft, inflammation spread through under ligament of the stapes and round window membrane. It can follow staphylectomy or fenestration operation. Clinical feature being mild cases complain of vertigo and nausea, but in several cases vertigo is worse with marked nausea, vomiting, and even spontaneous nystagmus. And quick component of nystagmus is diffuse cochlea is also affected with some degree of sensory neural hearing loss. Serous labyrinthitis, if not checked, may pass to the suppurative labyrinthitis with total loss of vestibular and cochlear function. Treatment being medical treatment, patient is put to bed, his head is mobilized with the affected ear, and the antibacterial therapy is given in full doses to control infection. Labyrinthine sedatives, that is prochlorperazine, stametil, or dihydrogenate dramamine, are given for symptomatic relief of vertigo. Meningotomy is done if labyrinthitis has followed acute otitis media and the drum is bulging. Thus, the pus is cultured for specific antibacterial therapy. And surgical, we say it's the basically cortical mastectomy in acute mastoiditis or modified radical mastoidectomy in chronic middle ear infection or cholesteatoma. Will often be required to treat the source of infection, that is medical treatment should always precede a surgical intervention. Next is diffuse suppurative labyrinthitis. It is diffuse pyogenic infection of labyrinth with permanent loss of vestibular and cochlear function. Etiology being usually follows a serious labyrinthitis pyogenic organism entering through a pathological or surgical fistula, and clinical features seen in severe vertigo with nausea and vomiting due to acute vestibular failure. Spontaneous nystagmus will be observed with a quick component toward the healthy side. Patient is markedly toxic. Loss of hearing, relief from vertigo is seen after 3 to 6 weeks of adaptation, and treatment is similar to treatment of serious labyrinthitis. Drainage of labyrinth is required if intralabyrinthine suppuration is acting as a source of intracranial complication, meningitis or brain abscess. Intracranial complication, extradural abscess. Then what we have is basically subdural abscess, meningitis. Then what we have is autogenic brain abscess. Okay, so autogenic brain abscess is, we can say, this thing is, you can see in this diagram, cerebellar abscess. And the investigation, lateral sinus thrombophlebitis or sigmoid sinus thrombophlebitis we have. And then yes, last one being the otitic hydrocephalus. So guys, in complications of chronic suppurative otitis media, the complications which are important like labyrinthitis and acute mastocytitis, these two complications are discussed in very much detail, and rest other complication I gave a brief overview or just enumerated it because they were not so much clinically significant to be discussed now. Now I will discuss the topic which are left, that is autosclerosis, Meniere's disease, otalgia and tinnitus quickly. So first let's begin with autosclerosis. So what is meant by autosclerosis? Autosclerosis, more aptly is called autospongiosis, is a primary disease of bony labyrinth, and in this one or more foci irregularly laid spongy bone replace part of normally dense echondrial bone and layer of the bony otic capsule. Most common the autosclerotic focus involve the stapes region linked to stapes fixation and conductive deafness. However, it may also involve certain other areas of bony labyrinth where it may cause neurosensory hearing loss or no symptoms at all. Etiology being basically anatomical basis, in which there is a fistula antefenestrum lying in front of the oval window being the important thing. Hereditary cause, 50% of autosclerotics have positive family history, rest are sporadic. Genetics reveals studies that it is an autosomal dominant trait with incomplete penetrance and variable expressivity. Race, sex, age of onset and effect of other factors and viral infection. Types of autosclerosis in which we have is basically stapedial autosclerosis. You see this diagram carefully, that's stapedial autosclerosis. Second one, basically in that also we have 5 types, in which first we have is basically the anterior focus, posterior focus, then basically what we have circumferential, then biscuit type, and next one is the obliterative. These 5 types of stapedial autosclerosis. Next what we have is a cochlear autosclerosis, and we have a histological autosclerosis. Pathology being discussed, basically pathologically autosclerotic lesions appear chalky white, grayish or yellow. Sometimes it's red due to increased vascularity, in which case the autosclerotic focus is actively rapidly and progressive. And basically microscopically what is observed is basically spongy bone which appear in normally dense echondrial layer of otic capsule. In immature active lesions, numerous marrow and vascular spaces with plenty of osteoblasts and osteoclasts and lot of cement substance which stains blue. Symptoms being hearing loss, paracasis villi, tinnitus, vertigo, and speech. Signs being tympanic membrane being quite normal and mobile. Reddish hue may be seen in the promontory through tympanic membrane. Eustachian tube function in normal. Tuning fork test shows negative Rene, that is first for 256 Hz and then 512 Hz, and still later when stapes fixation is complete for 1026 Hz. Weber test will be lateralized to the ear with great conductive loss. Pure tone audiometry shows loss of air conduction more for lower frequencies, and bone conduction being normal in cases deep in conduction curve basically different at different frequency, but maximum is 2000 Hz is called Carhart's notch. You can see over here maximum 2000 Hz being Carhart's notch, and then basically you can see the dip is observed and disappears after successful stapedectomy. This very important. And then you can see speech audiometry reveals normal discrimination score except in those with cochlear involvement. Tympanometry may be normal in early cases but later shows a curve of ossicular stiffness. Stapedial reflex become absent when stapes is fixed. Talking about differential diagnosis, otosclerosis should be differentiated from other conditions causing conductive hearing loss, particularly serious otitis media, adhesive otitis media, tympanosclerosis, arctic fixation of head of Milius, ossicular discontinuity, or congenital stapes fixation. Treatment medical involves basically sodium fluoride has been tried to hasten the maturity of active focus and arrest the further cochlear loss, but controversies exist in this treatment is not recommended generally. Therefore, there is no medical treatment that cures otosclerosis. Next being surgical treatment, stapedectomy or stapedectomy with the placement of a prosthesis is a treatment of choice. The fixed otosclerotic stapes is removed and a prosthesis is inserted between the incus and oval window. Prosthesis employed may be a Teflon piston, then it may be a stainless steel piston, platinum Teflon or titanium Teflon piston. In 90% of patients, there may be good improvement in hearing after stapedectomy. As you can see, stapes prosthesis. This is known as a Teflon piston. So this is basically before removal of stapes, and stapes removed and replaced by Teflon piston. That's a Teflon piston. That's a platinum Teflon piston, and that's a titanium Teflon piston. So selection of patient for stapes surgery. Hearing threshold for air conduction should be 30 decibel or more or worse. In this level, basically patient will starts feeling socially handicapped. An average airborne gap should be at least 15 decibel with Rene negative for 56 and 512 Hz. Speech discrimination score should be 60% or more. Contraindication to stapes surgery. The only hearing aid is better in such cases. Acute associated Meniere's disease, when there is a history of vertigo with clinical evidence, and Meniere's disease in an otosclerotic patient, there are more chances of sensorineural hearing loss after stapedectomy. Young children, that is recurrent Eustachian tube dysfunction is common in children. It can displace the prosthesis or cause the acute otitis media. Also, growth of otosclerotic focus is faster in children, leading to reclosure of oval window. Next, what we see is basically the professional athletes, that is high construction workers and drivers and frequent air travelers. Stapes surgery has a risk to cause post-operative vertigo or dizziness and thus interfere with the profession. So frequent air pressure changes during flight may damage the hearing and cause severe vertigo. Those who work in noisy surrounding after stapedectomy would be more vulnerable to get sensorineural hearing loss due to noise trauma because of the stapedial tendon is cut into protective function of the stapedius is lost, and otitis externa, tympanic membrane perforation and exostosis are relative contraindication. Stapedectomy can be done after they have been treated first for the above condition. Similarly, stapedectomy is avoided during pregnancy and the operation is preferably done under local anesthesia. Now you need to see this diagram. This diagram represents the steps of stapedectomy. So first being the incision. What is incision happening? So basically there is a meatal incision and elevation of the tympanomeatal flap. So here what we have seen, this is the meatal incision. Here we have done the incision and we have basically elevated the tympanomeatal flap, and it's the reflected forward. It is posterior superior bony overhang to be removed. So that's the posterior superior bony overhang which has to be removed. Next is basically posterior superior overhang removed to exposed facial canal and pyramid. You can see this is the facial canal and that's the stapedial tendon, that's the chorda tympani pyramid. Next being basically stapedial tendon cut and stapes superstructure is removed. So stapes superstructure is removed and stapedial tendon being cut. So here there was a stapedial tendon. Have you seen this? Yes, this is a stapedial tendon and now the stapedial tendon is cut and the stapes superstructure is removed. Next being the small fenestra which is made in the foot plate and the Teflon piston is inserted. That's a small fenestra you can see which is made in the foot plate and Teflon piston is being inserted. So that shows basically the step of stapedectomy, that is meatal incision and elevation of tympanomeatal flap, exposure of stapes area which may require removal of posterior superior bony overhang of the canal, removal of stapes superstructure, creation of a hole in the stapes foot plate or removal of a part of foot plate, places of prosthesis as I shown. These are the different types of prosthesis: Teflon piston, platinum Teflon piston and titanium Teflon piston. So repositioning of the tympanomeatal flap. Next being the complications of stapedectomy: tear of tympanomeatal flap and later perforation of the tympanic membrane. First. Second, injury to the chorda tympani with taste disturbance, particularly if opposite chorda was early injured. Third, incus dislocation. Fourth, injury to facial nerve. Fifth, vertigo. Vertigo early in post-operative period, that is intraoperative trauma, serious labyrinthitis and lung prosthesis, and late due to perineum fistula and benign paroxysmal positional vertigo. Next, perineum fistula or granuloma. 7. Conductive hearing loss, short prosthesis, loose prosthesis, displacement of prosthesis, and incus erosion. Incus erosion, which is late. Then we have basically sensory neural hearing loss. You have to understand that in sensory neural hearing loss, what we have is basically three types. In which we have basically first being the intraoperative trauma, second being the labyrinthitis, and third being the perineum fistula or granuloma, and the ninth one being the dead ear. So 2% of the patient undergoing this operation suffer sensory neural loss, and slowly progressive high frequency loss is seen in long term follow up. 1 in 200 patient get totally dead ear. Stapes mobilization is no longer done these days as this is temporary result. Refixation being quite common. Lampert's penetration operation is almost outdated now. Here an alternative window is created in the lateral semicircular canal to function for the obliterated oval window, and it has a disadvantage of post-operative mastoid cavity and inherent hearing loss of 25 decibel, which cannot be corrected. Hearing in patient who refuse surgery or who are unfit for surgery can use a hearing aid. It is an effective alternative. So guys, as we discussed, we completed chronic suppurative otitis media complications and otosclerosis. Now we have left with three topics. We'll go first otalgia and tinnitus, and then we will do the topic Meniere's disease. Meniere's disease is actually a very huge topic. We'll do it in this video only, but first let us complete otalgia and tinnitus. So now we will discuss about otalgia. Otalgia means basically earache. Pain in the ear can be due to causes occurring locally in the ear or referred to as it from the remote areas. Local causes include pharyngeal, then impacted wax, otitis externa, otomycosis, meningitis, villosa, herpes zoster, and malignant neoplasms. And middle ear it can be acute otitis media, eustachian tube obstruction, mastoiditis, extradural abscess, aero-otitis media, and carcinoma of middle ear. Referred causes as ear receives nerve supply from 5th auriculotemporal branch and 9th tympanic branch and 10th auricular branch. Cranial nerves from the C2 lesser occipital and C2 and C3 greater auricular pain may be referred to the remote areas. And via 5th nerve, you can go to dental, oral cavity, temporomandibular, and spinopalatine neuralgia, such as temporomandibular joint disorders such as bruxism, osteoarthritis, recurrent dislocation, ill-fitting denture. Then oral cavity, benign or malignant ulcerative lesions of oral cavity or tongue, and dental caries, tooth, apical abscess, impacted molar, malocclusion, and Costin syndrome. What's Costin syndrome? I want to tell is basically Costin syndrome due to abnormality of temporomandibular joint with defective bite. It manifests with tinnitus, vertigo, and earache, and it is caused blocked filling in the ear, associated pain in the ipsilateral, frontal, parietal, and occipital region. Treatment include analgesics, heart fomentation, slow TMJ exercises, and defective bite can be covered by an orthodontist. So this diagram represents how referred causes of otalgia is there. That is, pain is referred to the cranial nerve 5, that is teeth. We can see over here teeth, oral cavity, temporomandibular joint. Then we have anterior 2/3 of the tongue, teeth, oral cavity, temporomandibular joint, anterior 2/3 of the tongue. Then basically it is referred to next is basically a C2 C3 cervical spine, teeth, oral cavity, temporomandibular joint. Then we have basically C2 C3 cervical spine and cranial nerve 9, tonsil, base of tongue, elongated styloid process. And thus we have basically cranial nerve 10, which forms vallecula, piriform fossa, or larynx. Oropharynx, acute tonsillitis, peritonsillar abscess, tonsillectomy, benign or malignant ulcer of soft palate, tonsils, and pillars.
चालू करूया. कुठून चालू करायचं? इकडे बघ त्याच्या दादा माऊकडे बघ. बघ तिकडे हस हस हस. तिकडे बघ.
So causes of tinnitus being basically here you can see a long list of causes of tinnitus. So in which what we have is basically otalgic causes, that is impacted wax, fluid in middle ear, acute otitis media, and also sorry guys for the very big disturbance, but a kid is sitting beside me. Yes, and basically otalgic impacted wax in the fluid middle ear, acute otitis media, chronic otitis media, Meniere's disease, prebicuspus, then noise-induced hearing loss, idiopathic sudden SNHL, acoustic neuroma, metabolic hypothyroidism, hyperthyroidism, obesity, hyperlipidemia, vitamin deficiency, neurologic causes being head injury, temporal bone fractures, whiplash injury, multiple sclerosis, post-meningitic brain hemorrhagic abscess, brain infarct, cardiovascular hypertension, anemia, cardiac arrhythmia, arteriosclerosis, pharmacological cause being certain drugs used by patient, all ototoxic drug, psychogenic anxiety, depression, vascular AV shunt, congenital AV malformation, glomus tumors of middle ear, arterial root, carotid aneurysm, carotid stenosis, vascular loop pressing in seventh nerve in internal auditory canal, high riding carotid artery, persistent stapedial artery, venous causes, venous harm, then dehiscent jugular bulb, benign intracranial hypertension, patulous Eustachian tube, palatal myoclonus, idiopathic stapedial or tensor tympani myoclonus, dental TM joint disorders, and clicking of TM joint. Treatment talking about being basically reassurance and psychotherapy, techniques of relaxation, biofeedback, sedation, tranquilizers, and masking of tinnitus. Tinnitus maskers can be used in patients with no hearing loss. Tinnitus instrument with combination of hearing aid and a masker in one device looks like a hearing aid. Both hearing aid and masking device are independent volume controls. Now we will go to our last topic, that is Meniere's disease. Before that, have this some nice thing, guys. फ्रंट गिअर वापर, फ्रंट गिअर. फ्रंट गिअर कोणता असतो? हा डी, डी जिथे डी लिहिले तो. एक्सेल, हां गुड. हां तर स्टिअरिंग फिरव. हां गुड गुड चालो. Okay, so nice guys, back to our work. So Meniere's disease is basically Meniere's disease considered as an endolymphatic hydrops disorder of inner ear where the endolymphatic system is distended with endolymph. Pathology being the distension of endolymphatic system mainly affecting the cochlear duct, scala media, and the saccule. To a lesser extent, the utricular and semicircular canal. So dilatation of cochlear duct is such that it may completely fill the scala vestibuli and marked bulging in the resinous membrane. Etiology being defective absorption of endolymphatic sac, vasomotor disturbance, allergy, sodium and water retention, hypothyroidism, and autoimmune viral etiologies. Discussing in detail, basically normally endolymph is carried by endolymphatic duct to the sac where it is absorbed, and also defective absorption of sac may be responsible for hydrops ischemia of sac. Vasomotor disturbance interfering with the function of the cochlear and vestibular sensory neuropathy responsible for hearing loss and vertigo. Anoxia and capillaries of stria vascularis is also increase in permeability with translation of fluid and increased production of endolymph. Yes. Clinical features basically 35 to 60 years of age being the most common age group getting affected. Vertigo common in attacks. Then hearing loss, and we have tinnitus. Then we have basically the investigations include basically poor pure tone audiometry. Okay, so clinical feature may sense of fullness and pressure. Other feature being Meniere's this is like emotional upset due to apprehension of the repetition of attack. Investigation include basically pure tone audiometry, speech audiometry, then special audiometry test like recruitment test, SI, short increment sensitivity index, tone decay test, decay in less than 20 decibel, electrocochleography, caloric test, and glycerol test. These are clinically important tests, so we are not discussing in detail because right now it's not so important to discuss them in detail. Variants of Meniere's disease including cochlear hydrop, vestibular hydrop, drop attacks facing tumor kills, autolytic crisis, and Leroy syndrome, Meniere's disease versus Meniere's syndrome, and diagnosis of Meniere's disease, like certain definite and probable. Definite is combined by histopath. Certain is confirmed by histopath. Definite is confirmed by audiometrically documented hearing loss on at least one occasion, tinnitus or oral fullness. Probable one definite episode of vertigo and audiometrically documented hearing loss on at least one occasion, tinnitus or oral fullness in the treated ear, and other causes excluded. Possible episodic vertigo of Meniere's disease without documented hearing loss, and sensorineural hearing loss and also other causes excluded. Staging of Meniere's disease basically 0.25, 1, 2, and 3 Hz with the rounded to nearest whole. First audiogram during a period of 6 months before treatment. So this is the staging of Meniere's disease. Stage 1 being pure tone, average in decibel, previous 6 months being less or equal to 25. Second being 26 to 40. Third being 41 to 70. Fourth being more than 70. Treatment includes general measures like reassurance, cessation of smoking, low salt diet, excessive intake of water, avoiding overindulgence in coffee, tea, and alcohol, stress, and bring a change in lifestyle. Avoid activities requiring good body balance. Management of acuity. Reassurance of bed rest, intravenous fluids and electrolyte administration, vestibular sedatives like diazepam, Valium or Calampos, Dramamine like we can see dimenhydrinate and avamine, methazine thiocet, promethazine thiolate, and perchloroperazine stemetil. Management of chronic phase includes basically vestibular sedative, vasodilators, diuretic, propanthalin bromide known as a probenthine, elimination of allergens and hormonal therapy. In hormonal therapy, basically what is given for hypothyroidism, endocrine disorder treatment, appropriate replacement therapy being given, that is cortisol of stress by change in lifestyle. 80% of patient can be effectively managed. Intratympanic gentamicin therapy, chemical labyrinthectomy. Microweak, basically small weak made up of polyvinyl acetate, measures 1 mm by 9 mm. Then being the surgical treatment, conservative procedures like decompression of endolymphatic sac, endolymphatic shunt operation, and sacculotomy known as a fixed operation. So basically this is then basically what we selective section of vestibular nerve, ultrasonic destruction of vestibular labyrinth, destructive procedure labyrinthectomy, and basically we can see intermittent low pressure pulse therapy, that is Meniere's device therapy. So what is in this therapy? It is observed that intermittent positive pressure delivered to internal ear fluid brings relief from the symptoms of Meniere's disease. Not only the improvement in vertigo, tinnitus, ear fullness, but also hearing may also improve, and intermittent positive pressure waves may be delivered through an instrument called as a Meniere's device, which has been approved by FDA. So what is basically mechanism of intermittent low pressure pulse therapy? That is, pressure waves pass through ventilation tube to round window membrane and transmitted to perilymph yellow and compress endolymphatic labyrinth to redistribute the endolymph pressure to sac and blood vessels. As you can see in this diagram, step number 1 being round window membrane को we give basically pressure wave pass, then pressure wave 2 through the perilymph yellow and compress endolymphatic labyrinth. Third being the basically redistribute endolymphatic pressure to sac. Third and fourth being the blood vessels. So this is the diagram of it. So yes guys, this was about all the topics we covered. I'll show you. See this. Here we covered chronic suppurative otitis media complication, Meniere's disease, otalgia, tinnitus, and otosclerosis. So what we aimed today was to cover these 5 topics which were left in our otorhinolaryngologica ear part, and those we have completed. I know there was a lot of background noise, but it's okay. I managed to still complete a video very successfully, and even in this video I provided you a little entertainment by bringing a small kid who was actually untreated to a eye. So yes, very nice to see someone so small and having entertainment by the side. So it was good part, I guess. Okay, leaving that, I covered all the other topics which were we fixing up that we will cover in this video. Yes and yes. Thank you so much and stay tuned.